Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Trastuzumab plus Adjuvant Chemotherapy for HER2-positive breast cancer, planned joint analysis of overall survival from NSABP B31, now NRG Oncology, and NCCTG N9831, now the Alliance. The article was written by Edith Perez et al. My name is Harold Burstein, and I'm a medical oncologist at Dana-Farber Cancer Institute and Harvard Medical School, both in Boston, Massachusetts. My oncology specialty is breast cancer. 2005 was a landmark year in breast cancer management because of the adjuvant trastuzumab data from the NCI cooperative group studies led by the NSABP and the NCCTG. Before a standing room audience at the Convention Center in Chicago, investigators showed that adding trastuzumab to chemotherapy reduced the risk of breast cancer recurrence by half. The near-term effects were so obvious as to make any commentary superfluous. From the back of the amphitheater, it was apparent that women with HER2-positive breast cancers should receive trastuzumab. Oncologists went home that week and began to add trastuzumab to the treatment regimens for early-stage HER2-positive breast cancer. Because of the so-called Will Rogers effect, trastuzumab helped the outcomes for all patients with breast cancer. Those women with HER2-positive tumors had historically had worse outcomes than any other cohort of breast cancer patients, dragging down outcomes for the whole population of breast cancer patients. By separating out the treatment plan for women with HER2-positive cases, trastuzumab boosted the results for those patients. And by taking out these so-called bad apples from the mix, trastuzumab indirectly helped the averages for all patients with breast cancer. But there were questions. What was the best way to give trastuzumab? How long should trastuzumab be given? Should it be given with chemotherapy or after chemotherapy? What would the effects be in different clinical subsets? Would the results prove durable? And what were the long-term side effects? Over the past 9 years, we've learned the answer to many of these questions. We know that 1 year of adjuvant trastuzumab is the optimal duration. Longer durations do not improve the results, and shorter durations are not quite as good. We know that giving chemotherapy concurrently with trastuzumab is modestly better than giving chemotherapy first and then following in sequence with trastuzumab afterwards. We have extended the use of trastuzumab into the treatment of lower risk, stage 1 breast cancers, a group not significantly represented in the original studies, and it's been shown that trastuzumab dramatically improves the outcomes for these patients. The report that accompanies this podcast from the NSABP and NCCTG provides important information on the long-term effects of adjuvant trastuzumab. The data in 2005 represented a median follow-up of only 2 years. The current data represent over 8 years of median follow-up and include a larger percentage of patients with 10 or more years of follow-up. What do we learn from this long-term follow-up? First and foremost, we learned that the benefits of trastuzumab are robust and durable. There remains a 40% reduction in disease recurrence and a 37% improvement in overall survival. These proportional risk reductions translate into meaningful differences for all identified clinical subsets of HER2-positive breast cancers: the young, the old, and everyone in between, node-positive and node-negative presentations, and tumors that are ER-positive and ER-negative. We see confirmation that trastuzumab lowers the risk of distant metastatic recurrence and also lowers the risk of local regional recurrence. We also see important confirmation of the long-term safety of trastuzumab. There was no suggestion of an increase in the incidence of secondary cancers associated with trastuzumab. Even among patients receiving anthracycline-based chemotherapy, the incidence of death from hematologic malignancy was extraordinarily low at 0.09%, or 2 cases in more than 2,000 women. Cardiac toxicity has been the most concerning known side effect of trastuzumab. There was a small numerical increase in the incidence of death from cardiac conditions with the use of trastuzumab, but the absolute risk of cardiac death is exceedingly small, 0.4% with trastuzumab versus 0.1% without, a difference of 0.3%, which is dwarfed by the survival advantages of trastuzumab overall. These findings provide a handsome bookend to the adjuvant trastuzumab story that began in 2005. We are probably on the cusp of a new era in the management of HER2-positive breast cancer, as a new generation of anti-HER2 targeted drugs seems poised to enter adjuvant therapy for early-stage disease. But before moving on to those hot new drugs, it's appropriate to reflect on these trials of adjuvant trastuzumab, which were superb models of clinical research. They were straightforward, Phase 3 trials, sponsored by NCI-supported cooperative group networks, and supported by the deep engagement and commitment of investigators and patients across and within the United States. There was a profound investment in correlative studies, including studies of predictive biomarkers, centralized tissue review, and cardiac function. There was cooperation between the NSABP and the NCCTG to share data, which enabled the release of important data much earlier than would have been the case if the data had been hoarded by an individual group. And there was the commitment to long-term follow-up that solidifies the study findings and sets the benchmark for the next generation of studies for anti-HER2 treatments in early-stage breast cancer. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.